Hi, I'm Dr. Paula Redmond, a clinical psychologist, and you're listening to the When Work Hurts podcast. On this show, I want to explore the stories behind the statistics of the mental health crisis facing healthcare professionals today, and to provide hope for a way out through compassion, connection, and creativity. Join me as I talk to inspiring clinicians and thought leaders in healthcare about their unique insights, and learn how we can support ourselves and each other when work hurts. Burnout is a really hot topic right now. We know that increasingly high proportions of NHS staff are reporting significant levels of burnout. But what exactly is burnout, and what can we do about it? In this week's episode, I put these questions to Dr. Julie Highfield, who is a Consultant Clinical Psychologist in Adult and Pediatric Critical Care and the National Wellbeing Director for the Intensive Care Society. I started off by asking her to define burnout, as it's a term that's often used to mean a range of different things.
I completely agree with you. I think it's often misconstrued. So we have to think about the kind of three elements of burnout together. So that chronic state of emotional exhaustion. So that's element one. Feeling disconnected from the work or cynical is element two, along with that feeling of getting nowhere. So that not really achieving much at work. And all of those three things together are what constitutes burnout syndrome. And that's the really important thing. It's syndrome. It's not a diagnosis. It's a cluster of symptoms that occur together. It just made it into ICD-11, actually. So, yeah. And I think the other thing is importantly recognized as not a mental health condition, but a work-based phenomenon. So, the more kind of recent researchers, Christina Maslach being the key one, has really pushed that it's an organisational phenomenon rather than an individual phenomenon. But I think so much of what we hear and talk about is very much on that individual case-by-case basis rather than recognising actually this is something that happens in clusters of people.
We've mentioned, that it can be something that is misconstrued or misunderstood. What have you found have been the most common misunderstandings around burnout?
I'm going to give myself as an example here today. So here I am, last day before 2 weeks annual leave, and I'm at my peak exhaustion, I would say. So it would be really easy for me in casual conversation to say, oh, I'm so burnt out. Like in casual conversation, people say, oh, I'm so depressed. But actually what I mean is I'm tired. Actually, it's time for a break. It's time to recharge the batteries. Do I still care about my job? Yeah, I love it. I love my job. Do I still feel connected emotionally to my job? Yeah, absolutely. I go up and down, but I still very much feel connected to the work. And, there are days where achieving something is a challenge, but it still feels like there's always the win. So in those terms, actually, all I really have is the emotional exhaustion, which just says I'm tired and I'm in need of a break and a sit back and a rest. And I think I often come across people in that position and I ask them, yeah, but how do you feel about your job? Do you still love it? Do you still get something from it? Do you still feel like you're getting somewhere? And that's actually really useful because I think particularly the people I work with are not psychologically trained. They're often nurses, doctors in acute settings, and they're used to diagnostic labels. So they hear this stuff in the press and, in Facebook memes and Twitter and all those sort of social media. And they're worried, is that me? Do I have this diagnosis? So I think it's quite often really, really helpful to help break it down with people and say, actually, no, you're emotionally exhausted or you're tired, really. Different side of it that I have to say, I tend to see the exhaustion more in nurses. In doctors, I tend to see the more kind of disconnection. And actually, it's really important to recognise the difference between burnout and rust out, actually. And I think clinical psychologists are dabbling quite a lot in the area of kind of workplace wellbeing, aren't we? I'm there too. And actually, it was an organizational psychologist that taught me that concept. It's really well known in organizational psychology. So that rust out is basically my job's just not stretching me anymore. I'm a bit bored. I'm a bit disinterested. So actually, that's a really important thing that a lot of people will get to when they've got everything they can get out of their job. And so that sense of not achieving and that sense of disconnection is in fact, actually, I'm ready for the next challenge rather than they're unwell or struggling with burnout.
Oh, that's a really nice distinction. And do you think, so within those three parts of burnout, and you mentioned there that you kind of see nurses experiencing more emotional exhaustion, doctors might be the more disconnected. So I guess, is there a sense that people might have a kind of profile within those three parts, that for some people it might be more, they might have features of each, but they might have more of one than the other?
Yeah, so I mean, this is part of a study that I conducted with the Intensive Care Society in 2019. Actually, we've got a paper out about it and exactly that. So obviously within the area of critical care, but I think you can see it sort of the findings expanding to other kind of areas. So what we found were the allied health professionals and nurses were higher on the emotional exhaustion, whereas doctors were higher on the disconnection, dissatisfaction. What's interesting is Maslach's research says that those are the two most important components, that actually the sense of achievement is almost like an independent factor that runs alongside. So yeah, certainly thinking about that profile, well, actually you think about the nature of the work of a doctor making difficult decisions, potentially breaking bad news, potentially withdrawing life-sustaining treatment, etc., those sorts of things. Actually, if they're too emotionally connected to the work that they do, it's quite damaging. So you can see that at one point, actually, a little disconnection from the work is actually quite helpful. It's just when it tips to the other side, and that's kind of links to the whole intelligent kindness kind of literature, which would be a really good thing to talk about in a bit. The emotional exhaustion side, in terms of nurses, where actually you think doctors can step away from the bedside. Nurses typically, in intensive care, they're at the end of the bedside, 1-to-1, 12-hour shifts. There's really interesting stuff from Jill Mabon that says fatigue kicks in at 8 hours for nurses. So they spend 4 hours of their shift, so a third of their shift, in mini emotional exhaustion, if you like, in mini compassion fatigue. So you kind of think, is that almost inevitable because of the way we set up shifts? So, allied health professionals are somewhere in between. They can step in and out, but they tend to be more present. I think you look at other areas, kind of wards, where you haven't got the same intensity of ratios, but it's still the case that nurses and allied health professionals are forever present. Doctors step in, step out. So it's almost something about the nature of the work lends itself to which part of burnout might be emphasised.
And I also want to ask you about, you said, burnout isn't a mental health diagnosis. It's understood as an organisational phenomenon. But where does that lie with mental health problems? Where are the edges between burnout and depression, anxiety, and also trauma? Because I suppose I wonder whether sometimes people use that word and there isn't specificity around what people mean, whether they are depressed or burnt out rather than depressed, and whether actually, particularly I guess over the last couple of years, whether there's a lot of trauma around and burnout is an easier thing to hang that on.
Yeah, I mean, it's a difficult one. And again, it's that tendency to put a diagnostic label on it, rather than, as you and I would want to be more kind of formulation driven and understanding the context. But I guess that is the nature of their setting. So that, they like that diagnostic shorthand, don't they? I think for me, I think about kind of a couple of sort of case examples in my head and sort of typical profiles. As you say, what I find is that there's a lot of people I've worked with that have been constantly on, if you like. They've worked hard, they've had to do more in the context of having less resource to give to each patient and family member. So this is where our friend moral distress, or it's not really that friendly, is it? But it comes in terms of that discrepancy between what they would like to provide and what they're able to provide. That kind of gap in the middle, I think, forces people with integrity, clinical integrity, to work harder to fill that gap. So you think, okay, well, what are you doing there? You're actually pushing that emotional exhaustion. You're giving, you're giving, you're giving. I think alongside that, although, where I work in intensive care, it is a high vicarious trauma environment. I think what I see is a lot of almost lacking space to process emotionally. So it's each thing that they see, they don't necessarily have the catharsis to let it go, because the next thing and the next thing, and obviously in the pandemic, it's next. It's just high frequency, really, of the same thing, but things that they're trained to do. So what you can have is that almost that emotional blocking. And I think it's the stuff of kind of, this is where almost the crossover between diagnostic labels, isn't it? So you think about that kind of emotional avoidance that can happen, and trying not to think, that things kind of pushing through and intruding. So such would click those diagnostic markers for trauma. But actually what lies beneath it is that chronic state of being on all the time, and chronic state of activation. I think you can get kind of anxiety or depression in the mix depending on people's sort of personality baseline. So for some people, that chronic state of on just then spreads, and it kind of becomes those worrying thoughts. They start to think about what's going on at home, etc. They've witnessed bad things. They extrapolate those bad things to their home life, versus someone who's more perfectionistic, self-critical. Actually, it will flatten their mood. So there's so much crossover. And I have to say, I work in a sort of fairly kind of medium scale tertiary referral centre hospital. And I went through everyone that has come to me over the last 2 years and just looked at my sort of one or two sort of word label for what they've been through. And only one or two of them could I give that clear sense of, that's definitely PTSD. That definitely fits in the realm of burnout. I think often it just feels like a messy quagmire, really. And I think that's what's not helpful for staff. Within it, I think that the sadness and the complexity is that actually most staff are exhausted right now. Some of them are disconnecting from the work to protect themselves. So it's almost like burnout is coping. Part of that disconnection interferes with good trauma processing, because you're trying to disconnect and care a little less. You don't want to think about work outside of work. And for some people, instead of seeing that as a systemic failure in the NHS, they will point that arrow inwards. So it will affect their mood, it will affect how they feel about themselves. Sometimes part of the work I do is to help them to not feel upset with themselves, but to recognize actually that that's system failure. But the problem is that's out of our control, isn't it? So in many ways, it's easier to bash yourself with a stick and improve yourself, because the system is big and rusty and a bit of a mess.
And it's really tricky working in that space, the kind of workplace well-being, or, the work that I do, which is largely individual work, where you're coming up against that all the time, that the causes of burnout are, these big systemic complex issues that as individuals we can't change. But the impact is so personal, and how we find ways of making sense of that doesn't cause more harm, but is in some way empowering in order for people to keep going or decide not to, whatever is going to be most useful. I wonder how you navigate that working within the organisations in terms of that fine line between offering support and not. I don't know, I struggle with the whole kind of resilience thing, because I think not necessarily the idea of resilience, but the way it's used to locate the problem within individuals and the solution within individuals.
Yeah, it's a tricky one. I too struggle with the word resilience. It's not a bad word, but just like compassion, it ends up being almost a way of saying, well, you're the problem. You need to be more resilient. You need to be more compassionate, rather than how do we enable and harness your resilience? How are we a resilient system? And also, how do we enable that compassionate system as well, etc., etc. And it's hard. I think it's always hard to have one foot in. And I think the way I've managed myself over the years is to always have one foot out, to try to position halfway in, halfway out. Because I think that the thing that was hardest for me at the peak of the pandemic, certainly, but I think it's always there when you're integral to a system, is the fact that you're thinking, yeah, I agree. And also, somewhat, me too. And it's really, really hard not to then collude with some of that negativity and almost the emotional contagion that can happen, because in an interesting way, someone comes to you and their words, and you think, gosh, that's really helpful for me to hear that you feel like that, which is one of those really, really hard things, I think, for any psychologist or anyone in that position of helping alongside kind of workers in that system. And in some ways, it would be nicer to be a bit more removed, think, because you could act more independently, because there's always that pressure of keeping the system going. So when you've got someone in front of you and you think, oh, there is no other best way for you to protect yourself other than to make a change.
Yes.
And that means to move.
Yes.
But I know in helping you to find that right way for you, actually, you have a knock-on effect on everyone else. And that is a constant pressure.
Yes.
And I think the way I manage it is to just walk it like a tightrope every day.
And that's certainly something that strikes me, I guess, working very much independently in kind of independent practice, that I have got that freedom, that it does feel freeing to be able to really just think about what is right for this person, to think with them about that without those pressures. And it's tricky when you're thinking about that knock-on effect, because I think that's something that people feel a lot, that sense they know that if they step out, if they step back, the impact on their colleagues is significant. And I think that keeps people going longer than they should sometimes. It's very hard.
But then that's partly what lends itself to being that kind of organisational phenomenon, doesn't it? It's almost the ripple effect that goes through. So I think there is something of what that chronic workload pressure and then that lack of supportive resources, and by that I don't mean nice places to go, etc., although that helps, but that kind of lack of good leadership, lack of good training, inability to take a kind of a proper restorative break, etc. So that constant kind of no slack in the system, a sort of an unabled system, means that actually collectively that's why the burnout happens. And I think there is certainly something of, there are others that have just that little bit more energy, just that slightly different style that energizes and keeps other people going, compensates a little bit. But actually, to me, I find that they're the ones who are at most risk of true burnout, because they try so hard and they pull everyone else with them, that actually they do it at their own expense. And I think that is a risk of integrated psychologists in the system, but that's also a risk of a really good compassionate leader, etc., no matter what their profession. So you can see that there is that kind of knock-on team effect. Everyone's trying together to manage this. And then individuals, ironically, I remember it was one of the first things that I learnt when I stepped into the world of workplace wellbeing. And it was a talk from the UK Health and Safety Exec psychologist. And they said that there is evidence to prove that if you teach people self-care strategies in certain organisations such as the NHS, they become aware of how toxic their workplace is, and they do the ultimate self-care, which is to leave. So teaching resilience, in inverted commas, leads to higher staff turnover. Fascinating, isn't it? There is something of collectively we hang on in there together, but actually it becomes each to their own, and that's survival.
One of the things that I've noticed, and I want to check whether this is something you've come across, is that often people kind of seek help at the point of, often they use the terms kind of breaking down, getting very distressed, for example, in the car park, having arrived at work one day or leaving, and kind of feeling really overwhelmed and like something's shifted. But often it feels really tricky because the thing that happened that kind of sort of broke the camel's back was like a small thing. Just someone was a bit rude to them, and not that this is a small thing, but the annual leave that they requested wasn't approved or something. And I think people struggle to, when their response seems really out of proportion to this little event, but actually we can see how that's sort of just the tip of the iceberg of a whole lot of things. And I think there's something initially that happens just to help people understand that and understand their response. Is that something you see?
Absolutely. And it's usually that one case, that one patient, that one negative interaction with a family or with a colleague, or as you say, something like annual leave or something like that. But it's the tipping point, isn't it? And I think this is part of almost that sort of that chronic problem, isn't it, with burnout that builds over time. We think of trauma usually as incident related, whereas burnout is that toxic build-up in a way. And there is some evidence, the evidence around burnout is really interesting and slightly shaky, but there is some evidence that actually not being able to kind of emotionally offload and process is one of the kind of predictive factors for burnout. And you could see that actually, if you think of your example, and I've got a fair few examples like that myself, is just those people who just build and build and build and build, and there's no outlet and no let up, and actually all that building, each little block probably feels minor until they just tip over.
And I'm wondering if, to kind of step back a bit and maybe reflect on the past few years and where we are now. I'm curious to hear your thoughts, because I guess for those of us who pre-pandemic we were aware of burnout and massive mental health sickness within the NHS, and it was a big problem then. And then obviously we've had the pandemic and enormous pressures that people are facing now. I'd just be interested to hear your reflections on the kind of landscape of burnout over the last few years and where you think that's going.
Pre-pandemic, burnout was high. So the work we've done in intensive care said prevalence rates around about 1 in 3, which is pretty high compared to the general population. I think what I have seen in broader NHS workers is a pull out all the stops because we think it will be short term and we think this is important. We're part of history. We're doing the right thing. So what I certainly saw, it certainly in the first wave, a little bit differently in the second wave, was a all hands on deck and absolutely just expend all of your energy. And I think in many ways, people had no other outlets and felt that it was going to be short term. So they just thought, well, this is okay. This is okay to do. And you look at particular areas, ICU being one of those areas where lots of people joined in to help. And someone described that to me as snow days. So when you have a short term bad thing happen, but everyone just rallies and it's that blitz mentality and we can do it. And actually there was an awful lot of joy around. Let's not forget that we enjoyed being absolutely heroic during that time. I think many, many people did. I think probably the people who struggled the most were those people who were redeployed without choice. Actually, they're the ones that often get forgotten about. But I think that those that chose to and those that were already trained to felt like it's my time to shine, actually. What shifted was over time that social disintegration, though, didn't it? Because then everyone went back. Second wave, third wave, no extra help. And actually, the attitude by the third wave was, well, you've coped, so what are you complaining about? You don't understand that. Rather than gratitude, continued gratitude. So you could see with the pull out all the stops, emotional exhaustion side of things, people would just wore themselves out. But actually, what started to happen is almost this sense of the system doesn't care that you did that. Where's the gratitude? Where's the thanks? People have gone from banging pots in the street to swearing at people in A&E. I heard a story of the clapping in the A&E because someone actually managed to be triaged. So that is sarcastic clapping, if you like. So public attitudes have shifted towards the NHS, that sense of they're exhausted and they now feel entitled. And I think what then happens is that NHS staff then tap into that disconnection where they feel like, you know what, you don't care, I don't care. I'm going to just sit back. I'm going to work to rule. Actually, I'm not going to innovate. I'm not going to go on that social. If you can't be bothered, I can't be bothered. And actually, in amongst all of this, the system is so under pressure and overwhelmed, especially A&Es right now, where how can you ever feel like you're achieving something? It's actually really hard. So it's almost like the landscape for the possibility of burnout has just grown and grown and grown. And in amongst all of that, people's personal vulnerabilities towards depression, anxiety have been triggered, and then people have had traumatic experiences in amongst all of that. But ultimately, the key thing I see, the depressing thing I see personally, is that the psychological contract of work has been broken for NHS staff. One of the predictive factors in burnout is reciprocity. So if we give and we receive, that protects us from burnout. If we give and nothing comes back in return, we're more likely to experience burnout. So that reciprocity that was implicit in the NHS, hard to grab, but that gratitude seems to be slipping. And actually it feels like to be kind to sort of managers, executive level, etc., it feels like it's not there for them either. Actually, I don't feel like they're being the mean ones. I feel like, if we were to kind of think about in terms of sort of compassion focused ideas, I think everyone is in threat mode and they're just in their silos protecting their own. And and this is the thing that I've seen that's worse within that is that pro-social behavior is really on a knife's edge in the NHS right now. You have little glimmers of it, and it's joyful when you get it. But generally speaking, people are edgy with each other now. And I think a lot of people have checked out because of that broken psychological contract. It feels like this is not what I signed up for. I'm not getting that implicit reward anymore. I'm just going to either work to rule presenteeism and check out to protect myself, or, as we're seeing in the droves, leave.
And as you were talking out, it's just come to mind some of the kind of senior managers I've worked with, which has been very enlightening because they talk about exactly the same stuff. Often being shouted at, being expected to just pull rabbits out of hats, and a kind of creep of what's being asked of them, constant kind of more and more and more. And it seems small, but then when you look back, as you said, it's not what they signed up for. And it's impossible. It's impossible. So they can't feel good that they've achieved something because they've been asked to do impossible things. And putting them, sometimes teams, I think, get fractured and particularly at senior levels when it can be, may not have many peers, when departments or functions are then fighting each other for resources. It's horrible.
It's grim, isn't it? I mean, considering we're in the kind of provision of healthcare, aren't we? I often think we forget the care bit, but then also out of kindness to people, there's the inevitability of it as well, isn't there? We function in teams if we know each other. The maximum number is thought to be around about 10 to 12 people. But the teams I know are teams of 25 with a leader and 11 teams of 25. So actually, it's not really teams. That's arbitrary. Actually, that's just around kind of functionality of doing appraisals and signing off annual leave. There isn't that true social connection and that social embeddedness. And you're right, I think senior managers feel quite isolated. I think there's a lot of kicking up as well that happens towards managers as well, who are not supported in that position but feel that sense of responsibility.
So, Julie, what can we do? Thinking about what helps from, in a kind of individual level, a team level, and maybe an organizational level as well. So shall we start with the individual?
Yes,
maybe?
let's.
What helps?
Trying to unpack it, really. I think that there are some researchers that think the opposite to burnout is engagement. So I often think to people, what re-engages you, what reconnects you with what you do. So when I'm talking to an individual, yes, I'll talk about things like their kind of stress management, their emotional regulation, all of that outlet for that stress. But I'm also thinking about what's coming in, what's invigorating you, what's connecting you. So I'm really thinking in terms of if we can manage the emotional exhaustion through boundary setting, through taking time out, to pacing. But actually the more kind of underlying problem is managing the connection. And reconnecting rather than that disconnecting. So I will talk to people about almost finding one thing each day that feels like this is why I do this job. So thinking about their core purpose, what they enjoy about the job, why they do that job. That's a really hard thing to do, but I think that's the thing that they need to kind of almost reshift their focus onto. And there's different ways of doing that, through conversation, through keeping diaries, etc. But in essence, pay attention to the good stuff, the stuff that matters to you, to feel a sense of being reconnected with the work, and celebrate every moment of achieving something. Within that achieving something, it's finding that gratitude for achieving something. So sometimes that means that actually what they need to do is go get some feedback Go talk to their co-workers, go talk to their team leader, see what could be forthcoming, just to reinforce actually you're good at this job and you do well, to help them kind of feel reconnected with the work. That's the main thing I do. What do you do?
Yeah, I mean, for me, it comes back to these 3 C's: compassion, connection, and creativity, which is exactly, I guess, what you've been talking about there: compassion of looking after ourselves and supporting our needs and caring for what we've been through. And then the connection about, as you've said, kind of reconnecting with work. But I also wonder about, I often find that what's also helpful is for people to connect with things outside of work, because I think especially for health professionals, when your identity and your kind of self-worth is so tied up with your job, and then that just feels like it's sucking your soul and there's no way out, to kind of open up to other identities and other things that bring you joy and meaning in life.
Yeah, I'd agree. And I think that's probably one of the things that really caused that counterbalance in the pandemic, didn't it? In terms of where is my connection to my wider self? And actually people thought there's nothing else to do. I'll work. And the balance is tipped. And I think a lot of what we're seeing now in terms of people changing the nature of their jobs is because they're kind of thinking, after everything we've been through, work is not my priority anymore. So I think that's a really good thing. And I guess for me, you're right in terms of that. I think almost that a driving factor towards burnout is overwork drive as well. So feeling like, oh, I do more. Coming back to those energetic people who keep others going, they're the ones that seem the most vulnerable, because they sort of say, let's try this, let's do this, let's do this, and kind of overwork, and then almost check out as reach peak capacity. So having things that meet that need for drive but aren't work related, where they might achieve outside of work.
And that's where I think creativity can play a really great role in kind of meeting some of those needs, but connecting to other things and kind of being able to rest, especially if you're someone who is very driven, finding ways of being able to rest while still being active.
Active rest, yeah.
Yes.
I use that phrase quite a bit. I think the people I work with, and I find I'm the same, struggle to sit still. So don't like the idea of relaxation or meditation or things like that, but love the idea of paddleboarding, cycling, DIY, gardening. So, but then feel that that's bad. So I have coined that phrase of active rest to help them feel that almost permission to, that's how you can unwind through activity. And also, I think that utility of movement and anything that's complex in a visual spatial way, we know that really helps with trauma processing.
And for me, I know I talk about this a lot, but knitting is a great example of that.
I'm terrible at knitting, so that wouldn't be one for me.
It's not for everyone. But I think it has all of those elements in it of being able to connect to things that you love, people that you love. If you're making something for someone, it can be very complex, but also helps you to rest and kind of tune into what you need a bit. So,
do you want to know what mine are? I cultivate succulents.
Oh, wow. Yes, I can see beautiful plants behind you now, Julie.
Yes. And I found, because I sort of got into the research around kind of different ways of trauma processing, I found really highly complex jigsaws, honestly. I've never been a jigsaw person. I've always thought it was a bit middle-aged. Um,
Mm.
and my husband bought me a couple of really complex jigsaws, not last Christmas, the Christmas before, and complex Lego as well, actually, the Saturn
Yes,
V
yes,
Lego. And just incredible how you can absorb, but also it just enabled my kind of thinking to sort of get clear. And I found I could just kind of step away and go, oh, all right. So I would certainly recommend gardening Lego and
yes.
jigsaws to people.
Jigsaws. Yeah, yeah. Brilliant. So, Julie, what about if we think at a team level? Because, often people talk about how the team is the thing that keeps them going, those relationships within the team. It can also be the thing that causes a lot of pain if there is division and tension. But what can we do at a team level to support each other, ourselves?
I think, a key thing that we should do at a team level is spend any time together actually being a team instead of arbitrarily calling ourselves a team. So obviously if there's chance for something social, that can be useful, but not everyone wants to engage with that kind of thing. And there's the pressure of what kind of activity. I think I've always found over the years the space to come together and reflect on the nature of what we do is surprisingly powerful. And I think, models such as Schwartz and all the evidence for that, but doing that on a very mini level, because actually getting hundreds of people together is really hard work as per the Schwartz model. But I would get sort of 5, 6 people together to talk through something that's happened at work. But actually, part of that is about processing an emotional outlet for the sort of emotional toxins that are building. But the team-based learning is learning how to be better for each other, hearing each other's perspectives, realizing they're not alone. So you're in that connection, you're reconnecting the team. I think one of the really tricky things is there's been so much turnover in the NHS that actually that sense of team is really unstable. But it surprisingly doesn't take a lot just to get to know each other. So I did this thing in my own service where I facilitated a half-day team event where half of it was a game around, everyone submitted their answers and then it was a game of guess who. Basically, guess who said this about themselves? And we just had a giggle with that. And I think the thing that surprised me is I felt great afterwards, actually. So it was meant for them, but I felt really good because I had that opportunity to connect. And then the other sort of half of it was sort of saying, this is what's going on. So they felt connected to almost their place within the system and know what they're contributing towards. So it's that sense of connection and that sense of belonging as well, kind of those two things and those perspective taking. I think that's quite important. I guess, there's a part of me that's a little averse to just plonking in something that feels like, oh, here's just an event for people to go to, because I think a really key thing around teams is feeling safe to be yourself, and that's psychological safety. And if there hasn't been almost the structure and framework of work to create that sense, then to say, let's all go on a kayaking course together, people may not already have that safety at work, and it may extrapolate and actually make things worse. So I'm very, although I'm not against that kind of team building idea, I think that works well when the team's already functioning, but just wants to take it to another level. I mean, there's something about the boundaries and the fundamentals within work which are key. I guess the other side to that, when you say we do that, I think what we can do is come up alongside leaders, supervisors, and help them to be in the position of doing that. One of the things that we have to be cautious of in psychology and in those positions, especially if we're integrated, or sometimes even worse if we're helicoptered in, is we can be the nice guy, we can play good cop, and that ends up just making the senior team the bad cop. You get me, but they've sent me to you. They couldn't be bothered themselves. So, and that's something I've learned over the years, is actually the better position for a psychologist is what I call a stagehand rather than the main event. Actually, we should be be enabling from behind the scenes and helping people think, what could I say? How could I approach this? How can I puzzle through what's going on with maybe particular tricky individuals in my team, or what's going on in terms of my team purpose. So I think there's that as a position, as well as being in that facilitating team awareness kind of space.
And what about at a more organisational level?
Well, my organisation, my NHS organisation, is one of 16,000 people. Because that's the way health boards are set up in Wales.
Yes.
So, I mean, most NHS trusts are about 4,000 or 5,000 people. My ICU is 350 people, which is the same size as the village I live in.
Oh, wow.
So I think it's really important to make that kind of distinction, because I kind of think about one of my random side things I do is I run the community cinema in my village.
Oh, wow.
It's lovely, but it's so hard to please everyone because it's film and it's so hard to please everyone. But it's a really important point of learning for kind of leadership in organizations, if you like, which is I can't get everyone in my village to agree. So why would we think that everyone in my intensive care would agree? There is more of a connected purpose in intensive care than there is in my village. But actually, it's the same number of people. So I just put that out there in terms of realism of helping at that organisational level. I guess, however, there are things that do seem to help. I think what helps as an organisation is setting that tone, and that tone of interest and caring and gratitude towards staff. I think it particularly helps to, rather than take that kind of position of, don't forget wellbeing services are here that you can self-refer to, don't forget to sign up to a course, blah, 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 blah. It takes much more of a position of, we recognise that you'll thrive at work if you're given those core conditions to thrive at work. And we recognise that that's about how we support your leaders. That's about how we enable your skill set. That's about how we designate your physical area. That's how we enable you to not spend 20 minutes hunting for a parking space before you have to come on shift. So from all of those kind of needs, a really interesting presentation, totally separate to psychology, but using psychology in terms of Maslow's hierarchy of needs, I saw literally a couple of weeks ago, where the guy said, if someone's not enabled at those core levels, you can't go up here. So we can't talk about self-actualization and what we're all here for if you can't park. You might think of it in a totally different area, in that we can't talk to people who are starving about self-actualization. And actually, this is something that's fundamentally kind of tricky at that organisational level in the NHS, isn't it? That other organisations don't struggle with, because Google doesn't have these conversations about burnout, does it? Google has conversations about thriving and psychological safety. But actually, the NHS doesn't get those first couple of levels of Maslow right. Actually, and it was infuriating during the pandemic to see out of work pilots coming into the NHS and setting that up for us. Is humiliating almost, because that's how bad it is. So I think that there are things that organisations try to do that are far too nebulous and disconnected from that core purpose. And it says so much more if a chief exec dons PPE and walks onto a ward than it does if they do a big Q&A. That's not to say they shouldn't do their Q&A, but actually it's in those kind of, again, coming back down to that social connection. If they walk around and they say, oh, hey, gosh, I can see how that doesn't work, and you've reported it and reported it, let me undo that chink in the system so that we can get your pipe work working, because your toilets and sinks constantly block, for example. That's an example from recently for me. So I think there's too much of an acting big and acting at a high level when we should really come down and get some of those basic conditions to work well. So those are physical conditions and those are tangibly skills to do the job. Another thing to add, sorry, hot off the press is about to be published a big study of demands versus resources in ICU nurses, actually. One of the really interesting things in terms of they measured burnout and PTSD and generalized distress. And what they looked at, multiple regression analysis, were what were the predictors of those? And demands of work are not predicted of those. It's the resources, but it isn't a leaflet as a resource or a cake stand as a resource. It's integrated resource of attitudes, approach, availability of leaders, education, all of those things. So those job-based resources, which I think is a really important thing to appeal to if there's any overwhelmed manager listening to your podcast. We can't reduce the demands in the NHS. In fact, they're going to grow and grow and grow and grow unless we start doing what they do in places like Canada, which is saying this year we don't do liver transplants, etc. They just cut services in order to do other services well. But what we can do is we can think about the way in which we get the basic resources right so that people can mitigate those demands, because people enjoy working hard if they're enabled to do so.
And I think there's something just about humanizing the system. And, you know, I think that links with what you were talking about, the reciprocity and, you know, just really seeing the workforce as people who have just, you know, basic needs that need to be met in order for them to do these very complex, demanding things every day, you know, day after day after day. And I think that's a real pain point for people, is when they just feel so dehumanized by the work. And I think, as you're saying, I think there's a role for us as psychologists, isn't there, to kind of just come back to those basics and keep banging on about it.
Yeah, absolutely. Yeah. So there's something else I want to add in terms of the individual. So I coined a new phrase with a colleague of mine, Matt Morgan, who lots of people know. He's very out there on social media. And we coined a phrase together, which was burn in. And the idea is, it's a theoretical idea, but we both strongly believe in it, is that actually people disconnect to cope. So they and people who are clinically facing disconnect to cope because they feel emotionally overwhelmed. And actually, that's bad for them. So instead of stepping back, we were talking about stepping in. So that idea, instead of burning out, you burn in. And it comes from Matt wrote a book, and I helped him contact various people that he wrote about in the book. And he said the thing that was amazing is that when he wrote the book, he learned more and more and more about people's in-depth stories. And he anticipated that would be bad for him. He anticipated that it, as an ICU doctor, that would overwhelm him, make it harder for him to do his work. If he humanized his patients and their families too much, then he wouldn't be able to make these really difficult decisions. And there's lots of kind of literature to suggest that. And it's something in that intelligent kindness kind of literature, Penelope Campling stuff, that does talk about sort of healthy disconnection from the work. And I would agree with that. But you can disconnect unhealthily, disconnect too far. So that idea that we talked about is actually, if you can reconnect with patients and patient stories, and you can find that humanity. There is a whole project called the humanization of ICU. Actually, it's a Spanish project, but staff often refer to a patient by their bed area, bed number, rather than their first name, or they refer to a patient by their condition rather than their first name. And they think that that's protective, and actually it causes more disconnection and burnout. So so it's just a cute phrase: burn in, reconnect.
Thank you for listening. If you enjoyed this episode and you'd like to help support the podcast, please do share it with others, post about it on social media, or leave a rating and review. I'd love to connect with you, so do come and find me on LinkedIn or Twitter. You can also sign up to my mailing list to keep up to date with future episodes and get useful psychology advice and tips straight to your inbox. All the links are in the show notes. Thanks again, and until next time, take good care.